And thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. A quick note, I've been on active surveillance since 2009, and I'm still a member of my local support group, which got me started on this journey. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment, but a management plan. I would like to remind everyone that we are not anti-treatment, but anti-unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during this meeting by our speaker, ASPI, or the audience should take the place of consultations with your medical professionals. We're going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. You can also click the raise hand button from the bottom of the Zoom toolbar, and if there's time, we'll try to call on you. Please keep your questions limited in scope. Our time here is limited, and our speaker does not have time to review your case history. During the meeting, please keep yourself muted. The speaker presenting here today is generously donating his time, and we want to be respectful of that. This meeting is also being recorded and will be available on our website in approximately 1 week. You'll get an email notifying you when it's ready. I'd like to remind everyone we also have a separate page of 1 minute video shorts derived from these meetings. And last, if you subscribe to our YouTube channel, you'll automatically be notified when the new video is posted. I'll quickly add here that we're always looking for volunteers, so if you have some time to help to spread the active surveillance word, please get in contact with us. We also appreciate your donations. No amount is too small, so if you can share, please go to our donate page on the website. One last item, there will be a short optional meeting survey today, which will pop up when you leave the meeting, and we would appreciate taking a few minutes to answer the few questions. So without further ado, we'll have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away, Mark.
Thank you, Bill, and thank you all for coming here today. And thank John Oliffe for his donating his time. I particularly appreciate those of you who keep us funded. If not for you folks that are donating to us here, we would have to be listening to the advertisements that I have to listen to when I listen to a podcast. I listen to Huberman Labs or Alan Alda and Clear and Vivid and some other podcasts. But when I listen, I have to listen to the advertisements. And the blessing is that you folks allow us to run this thing with our tiny budget, but it's due to all of you who make your donations. So thank you so much for that. And as long as you continue to do that, we're able to do this without having to run those ads that are a nuisance. And we at ASPI are doing a lot of innovative things here. Bill just mentioned the video shorts. They're searchable. So if you're newly arrived or with cancer, newly diagnosed with cancer, or have issues that you want to have researched along the way, we're the only ones that we know of that you can go to our website and get a 1 minute film on the issue that's important to you. And so we'd encourage you to check that out. Another first is our clinical trial page. We're the only clinical trial page that we know of where we list the active surveillance clinical trials. So we're doing a lot. And the thing is that the folks that run this thing, myself included, there's a lot of years of active surveillance and a lot of years of prostate cancer. So we care and we understand what you're going through. And that's why this thing works on such a small budget. Uh, and just a reminder that we have found in the last several meetings that the folks really want to stick around after the meeting and do a kind of an informal support group. So we do encourage you to stick around because we'll do that again today. And with that, I'll introduce Howard Walensky. Howard, I'm grateful you keep finding this incredible talent. So thank you for that.
Okay.
You've got it, Howard.
Mark, you forgot to mention too that we have at the website aspatients.org a series of videos that we call Active Surveillance 101. It's like a basic course in being on active surveillance with top people in the field. At any rate, I'm Howard Walensky, and good morning from Chicago. Thanks for being here. Today, we're going to talk about something that often stays in the background in prostate cancer, especially for men on active surveillance. It's anxiety, emotional distress, and the strain of living with uncertainty. We have some names for this, including anxious surveillance and scanxiety, those waves of worry that can build around the ramp up to PSA tests, MRIs, biopsies, and follow up urologist appointments, and especially experiencing this anxiety waiting for test results. A lot of men feel they're supposed to stay calm, stay strong, and just handle it. But we know it's often not that simple. In a survey we conducted 3 years ago of 450 men on active surveillance through ANCAN, ASPI, and other support groups in Canada, more than 50% told us they experienced anxiety or other emotional distress. And amazingly, 10% said they were so stressed out they were considering treatment, even though they were still good candidates for active surveillance. So, surveillance, I should say, emotional distress is not a side issue. It can shape how men feel, how they cope, and even the choices they make. That's why I'm so pleased to introduce Dr. John Oliffe. John is a professor and Canada Research Chair in Men's Health Promotion at the University of British Columbia, where he leads the Men's Health Research Program. I hope we will learn from him today about what anxious surveillance is and how we can cope with it. For more than 2 decades, John has been listening to men with prostate cancer and helping us better understand what we go through, not just medically, but emotionally. His work looks at how prostate cancer can affect a man's sense of identity, his relationships, his confidence, his sexuality, and his place in the world. He's shown that anxiety is not always spoken out loud. Sometimes it comes through as silence, withdrawal, irritability, anger, or loneliness. He's done important work on support groups, showing how much they can matter for men, providing a place where they can speak honestly, learn from one another, and realize that they are not alone. I think many of us will recognize these experiences either in ourselves or in men we know. So we're fortunate to have with us someone who has spent years bringing compassion, insight, and careful research to this subject. So please join me in welcoming Dr. Oliffe. John, will take it from here.
Yeah, thanks, Howard. What a what a lovely introduction. So thank you for that. Just want to just a shout out of thanks for being here on a Saturday. Like appreciate you taking the time, and I also appreciate Howard naming my talk because I wouldn't have come up with anything quite as creative as this. So thanks, Howard, for naming my talk. The prostatectomy doesn't cure anxiety. By way of background, yeah, I know you have lots of folks that come in and talk to you. I'm out of the University of British Columbia in Vancouver. We run the men's health program and have done for 20 some years. Movember is one of our great supporters who help us keep the lights on, so to speak, in the research program. And I'm fortunate enough to have a Canada Research Chair. And just to say that what that does is it redirects taxpayers' money toward me being able to do research and teach a little bit less than perhaps some of my colleagues do. So just to give you a bit of a sense, it's interesting for me to sort of be here. My background is prostate cancer. My PhD was in prostate cancer um, back in 2003, and since that time, I've sort of moved more fully into mental health. So it's a lovely opportunity to sort of talk to both today in the context of active surveillance of prostate cancer. When I show up at these gigs, I'm always, super supported by the team at Men's Health Research Program, made up of PhD students, master's students, undergraduate students, as well as some great help for managing the research program with Nina and Hannah, who's a research assistant. I know we've got Christy Chan on the call today. She's a PhD student and she's doing work in prostate cancer, and her work looks at the experiences of prostatectomy. So I appreciate we might not be able to recruit too many guys from today's call, but just know that we're in a good direction in terms of continuing to do some work in and around prostate cancer and specifically with Christy's work going forward. So stay tuned for Christy's contributions as we move on. I'm going to do 12 deliverables in 40-ish minutes. I'll just push that back a little bit. I do want to talk about an overview of Canadian men's health. We produced a report last year. I recognise that there's people on the call who are from all over the world. Just to say that we've done reports similar to this in the US, New Zealand, Australia, and the UK. And what I present to you in terms of an overview of Canadian men's health, it resonates. It's literally the same. So even though I'm providing a Canadian context, just know that in your part of the world, there's a pretty good chance that this is actually correct for the empirical side of things. I'm going to talk a little bit about anxiety, depression, and suicidality because it's really helpful to think about those things, what they are, what they constitute, and how we might think about those differently and differentiate them. And then I don't want to leave it with a kind of a doom and gloom kind of situation. I'm trying to locate it next to active surveillance and prostate cancer. And then I just want to give you some tips about some things that people say work for them, but also, some things that we know empirically, bank really well. I acknowledge there's heaps of expertise on the call here. 80, some of you, here with way more experience than I'll ever have. So, I invite a dialogue at the end too. A lot of times we learn from each other, and I think that's part of what these groups do really well. So I invite that. We produced this report at the end of last year. It's called The Real Face of Men's Health, and it was a Canadian report. And we did it with the support of Movember. I just want to give you a little bit of an overview because oftentimes prostate cancer is kind of positioned as the bastion of men's health. It's interesting because we tend to talk about men not living as long as women. So, in Canada, we're about 4.5 years short, in terms of those raw averages. But I think what's really important is to recognise that we say that about 44% of the deaths that occur are occurring prematurely. So when a guy dies before age 75, we recognise that as being grossly under the average of what we're expecting, for life expectancy. So again, we can locate what those things are, what cause those things. So our premature deaths are related to cancer, coronary heart disease, accidents, suicide, and chronic lower respiratory diseases. And these wash across the US, UK, New Zealand, Australia. You'll see these pop every time in terms of what those differences are in mortality or premature mortality, especially. It's interesting with cancers, that being the top one in terms of mortality. What tends to happen in the dialogue around this is we tend to sort of talk about, the things in terms of lifestyle. So, that guys drink more, they smoke more likely to smoke, eat less fruit and vegetables. We're more likely to be obese, have long-term risks, and we're much more likely to develop hypertension, coronary heart disease earlier on. So we tend to sort of default to lifestyle. We also tend to talk about guys not going to the doctor. So this notion that guys will wait, uh, on their symptoms before they act. Oftentimes they'll consult a partner and eventually go, but more, for about 9% of guys, they'll wait 2 years before they sort of act on symptoms. So these are all sort of men's health kind of general things that we know. And again, it gets linked, this idea that we don't ask for help gets linked to masculinity and the idea that we want to be self-reliant, we want to solve our own problems. And a lot of times we think, well, that's kind of old school. That's probably, my generation, your generation. But we notice that it prevails a lot of times, especially with young men. And so again, it's a bit of an ongoing issue and challenge for us. The thing in the healthcare system, the healthcare system is built around, kind of surgery and pills. It's a therapeutic model of care. And lifestyle changes, we don't tend to have the demand, but also, it's very, very hard to strike a conversation about everything's going well. I was just wondering if you could give me some advice about what's next if you're, seeing a general practitioner. So some of the things are kind of interesting. We default to lifestyle, but we don't always give good ideas about, how to manage it. And the therapeutic piece is usually about, when something's down the track and we're looking for a treatment. Um, there are some really unique things about prostate cancer and active surveillance. And when I was putting these slides together, I was really struck by how different prostate cancer is in terms of how we talk about men's health. And in particular, also in regards to how active surveillance fits with it. I won't workshop it now, but I invite you to, put your thoughts in the chat because for me, prostate cancer is very interesting. It doesn't always have symptoms. Sometimes we arrive in clinical practice and get a PSA inadvertently or a DRE inadvertently, and then we find we've got a bit of an issue, something to monitor or something to continue on with and explore further with a biopsy et al. So again, in terms of the behaviors we talk about with men and reticence for going for help, it doesn't always wash. And active surveillance too, there's this discourse about the need to be treated when you highlight a problem. So again, just be keen to sort of have your thoughts in the chat about, how it does line up to what I've given you at the front end or shared with you at the front end. Anxiety is interesting. Like by definition, anxiety is really about uncertainty about the future. And I mean, by definition, I think some of that prevails very much when you're doing something like active surveillance because you know that there's an issue, and you're choosing to monitor, and there's a whole discourse around, treatment. So again, just trying to think about, with anxiety, there's oftentimes noise from outside of ourselves as well. So, people will often have an opinion about, how things should be managed medically as well, and the advances in medicalization, treatment of prostate cancer and things like that. So there's a whole bunch of things that go on in terms of anxiety. What we noticed when we did this systematic review, this isn't specific to prostate cancer, but I think some of it washes really well. We tend to sort of see with guys, they'll have these what we call psychosomatic kind of pieces where they have chest tightness, maybe rapid heartbeat, shortness of breath, and then we'll see things like irritability, anger, and restlessness. Now, we might not always associate that with anxiety, but indeed they're absolutely cardinal signs of anxiety. And of course, when it's persistent and it interferes with everyday life, that's the differentiation when we're trying to, kind of label it and give it a name. So just to sort of say, this anxiety piece is one of the most commonly diagnosed pieces or mental health issues in men. And part of what sort of comes up with, mental health issues generally is that men have a perpetuation towards self-reliance rather than help seeking. because I don't always know what's going on. And there's a bit of a masculinity piece where we like to solve our own problems. So that toughness and emotional restraint, and I differentiate emotional restraint and emotional regulation further on in the slides here. And then there's this backdrop, especially around mental health, where we kind of get kind of laden with this idea that somehow it's about weakness and that we can't solve our own problems. And then we're indebted to someone who, is professionally providing help, and the stigma that goes with not being rational and decisive. So anxiety is one of those really interesting ones. Way back in the day, 2009, I did this paper with a bunch of folks out of BC here, and it was looking at the self-management of uncertainty. Um, and it was a group of 25 guys who were about 2 years into their journey, or under 2 years into their journey of active surveillance. And it was really interesting, speaking with those fellows. This is a little busy, but I'll break it down. Basically in talking to the guys and trying to see how they were managing uncertainty, which is a proxy for anxiety at varying levels. Like living a normal life, that positioning of prostate cancer as a benign cancer. But oftentimes disconnecting from self-care and disconnecting from family almost as a form of protection. So not really talking to them about it and disconnecting it from their everyday life. And the clinical implications for that on the left-hand side of this equation is that, you can lose those blokes to follow up, right? Because they're bracketed it off completely, and then they start to be difficult to manage or message in terms of protocols for the active surveillance. Of course, there was that living normal life, and then the guy who's already super healthy and he's already doing all of the things, and he's sort of got it in his mind, but he's continuing to sort of work through. And then there was a lot of guys who would be doing something extra. So that self or coached changer. So diet was big, exercise was big, complementary alternate medicines were big. And there was this connection a lot of times with the guys that we spoke to, at least, where they would, unite with their partner and sort of confront it as a team. And I think that was really interesting because it was often built around information and grabbing information and just being informed. And so, again, regardless of where, guys sort of line up here, and I'm not for a moment suggesting that we all fit one or the other. I think it's probably a bit of a blend at times, although we might perpetuate to one side of this equation or the other. It's just to say that, clinically, what we want to do is engage at the level that guys can engage around the AS protocols and keep them calm but cognizant. So, it's sort of where we came out with this. But I think this is actually anxiety management in many ways. So again, it's just working with the behaviors. So sometimes as clinicians, we get stuck on this idea of changing behaviors. And I sort of buy in at some level, but actually meeting guys where they are is super important, in terms of finding ways forward. There's, of course, literature, lots of literature since my time, writing in 2009. This one was interesting, just had a bit of a look at this, no difference in depression and anxiety with active surveillance versus treated. This one was interesting too, if you had pre-existing anxiety, depression, you were more likely to take a treatment than be on active surveillance. This one, again, quality of life was mediated, well, in active surveillance, quality of life and treatment. It was mediated by the trust in the doctor and the trust in the active surveillance protocol. Makes sense. And then this other one, qualitatively, which was a nice little paper, increased anxiety at diagnosis, and of course, increased anxiety when you're coming into those PSA checks. All makes sense. You can but from these details, you can kind of sort of like start to glean a bit of an idea about, when those anxious states might occur. And so I've got a few ideas, a few tips around that I'll share with you as we go. Depression is different to anxiety. Depression simply is ruminating on the past. Anxiety's worried about the future. Oftentimes they get put together. And what we see is a discordant relationship. And that's what I mean, a discordant relationship, as in we see high numbers of men suicide. So men suicide at 3 to 4 times the rate of females, but they're diagnosed with depression at about half the rate of women. So I'm not setting up a sex comparison here, but I am saying that we became very interested in how come, guys with depression were, being a pathway to suicide. So trying to think about that, about how that happens. And it comes down to three I's: injury, interiority, and isolation. So when we get injured, and it can be any type of injury, so these are photographs taken by some of our participants in research, and then they add the captions. And this is a young man who talks about, having his parents divorce and neither of them expressing a real interest in having him live with them, and then having a breakup with his partner himself and feeling abandoned. And it takes the picture of this abandoned apartment block and akin to that. The interesting thing about guys' injuries is that we tend to gloss over them. We tend to sort of go, 50% of relationships break down, it's not a big deal. I'll get past this, and so we often deny injury. And I would say, if you think about a prostate cancer diagnosis, if you live long enough, you're at increased risk, of getting a diagnosis. It's almost an artifact of getting older for a lot of guys. And so we also accumulate injuries as we get older. So the things that we sort of happen to us along the way, whether it be divorce, retirement, whatever, those injuries kind of accumulate as we go. And the interiority of what we do, we tend to look inward. So we like to be self-reliant, which is fair enough. I mean, in fact, we sort of celebrate that idea of being able to solve problems. So we look inward, and you can see this this is shared by a 30-something-year-old guy, South Asian guy, and he just talks about, if you know the combination, then you know how to get out of the depression and the suicide. But if you know the combination, you're able to unlock. So this idea that, this self-reliance around the interiority of dealing with your own problems. The challenge with this is that a lot of times, we push the emotions down. We don't actually deal with what's going on and deconstruct it. We're feeling things that sometimes are discordant. So sometimes you can feel regret and relief at the same time. And if we don't sit with those emotions and we just push them down, we kind of lose touch with our feelings. And then we become impaired in terms of our emotional regulation. So we're not able to recognize and manage the things that are going on for us. So that interiority is well intended. The most oftentimes thing that we see with guys when they're doing interiority is substance use to try and blunt what's going on. So you've had an injury, maybe cumulative injury if you've had a bit of a longer life. And then you've got this situation where, you're kind of looking inward and you really don't have the resources interiorly to deal with it. And then you will look to blunt with substance or a lie or some form of distraction. And then isolation. So, we often say that the biggest predictor of suicidality in guys is like this isolation piece, where we sort of, even when we're around people and we look connected for all intent and purposes, we're kind of not. And this is from a guy driving home from work, and he just, talks about you feel like you're just all by yourself. It's a feeling that's so unbearable that you just want to get rid of that feeling forever. So, and he's, coming home from a job where he's in an open office plan with 100 people around him. So he looks connected, but he's profoundly not for what's going on for him. The full paper's there. It's an interesting one because we sort of, we break it down. It's out of 2017. It's still popular because it does a nice job of helping us think about, what the trajectory is. And we've done some clinical work. This is Simon Rice, who heads up Movember these days. We've done some work in better trying to identify depression in men because we know that they show up with anger, irritability, substance use, and risk-taking. And so the generic screens for depression don't have that. So we've actually included this in the male depression risk scale. Simon's work is really good in this space because we firmly believe guys show up differently to the generic ways we might expect to see depression. We also see it in anxiety. A lot of times guys will show up angry and irritable. Just to say, I don't want to belabor suicidality and suicide, but just to give you a sense, Um, Suicidality is when we think about suicide, which is quite common. When we plan, which is less common, and when we attempt, which is even less common again. So collectively, those three things sit under the banner of suicidality. The three biggest causes in men for that is substance use, number one. Number two is relationship breakdown or distress. And number three is depression. So it's an interesting space where, we lose a lot of guys to suicide. Um, Again, not to do the sex comparison, but we die, 3 to 4 times more often than females with suicide. It's interesting when we connect with other guys. It tends to be oftentimes it'll be around booze or substance use, and this from a guy who's kind of lamenting that we just can't simply talk. So affirmation to you all being on a call where you're united around a particular cause and getting a conversation that's in a direction of problem solving and supporting each other because it's really, really important. But for many guys, they don't have that. So we also know that there's been a real, reckoning around alcohol. Canada's never, ever drunk less booze than it is at the moment. There's a real push around recognizing it as akin to some of the harms that are associated with tobacco. So certainly in terms of cancers and the like. So again, there's been this reckoning around substance use. It's getting kind of pushed out. The biggest growth in alcohol at the moment is non-alcoholic beer. And it's driven by men 30 to 44 who just aren't drinking full strength beer. It's very, very interesting. It's being sold as freedom, which is what booze was sold as back in the day. Super interesting. So billions of dollars in profits here. Many of these companies are selling this non-alcoholic beer, and there's a real movement towards it. What we're not sure about, and what we're sort of trying to investigate at the moment is, where people are in terms of their other substance use. So we don't think it's completely around abstinence. We think it might be something about fashion and moving away from alcohol into other substances. So again, just trying to keep an eye on that. The piece around relationships, so I mentioned relationships as particularly, vulnerable for mental health issues for men. And also, massively important, when it's a distressed relationship or a disrupted relationship. So, we know that men live longer when they're in a good relationship. We know that when it's distressed, their mental health is worse, their substance use is higher. When we talk to guys about relationship, they tend to talk to us about relationships happening to them. So a lot of times guys don't go in with necessarily a plan. Sometimes we run on autopilot within a long-term relationship as well. And the biggest place where people learn about relationships is, when they go bad, so in terms of the domestic violence in partner violence, that's where most guys get to kind of learn about relationships. So it's interesting because they move over time. And again, COVID, we saw such a pressure on the domestic sphere where everyone was kind of locked down. Our divorce rates have been much higher since then. So again, there's been a lot of pressure on relationships. Some guys line up pretty traditionally, so with well-established roles, in their relationship. So in straight couples, very much around who does what. And this is an example from a guy talking about, how he's wanting to have more control of the money, and the breadwinner provider protector piece has typically been that. So that kind of traditional relationship, you might see yourself in this, you might not. There's one about equality. So this is a guy talking about how relationships, need to be equal. And this works really well. And this is a young man. So talking about, this, he just moved in with his girlfriend and, having half the dresser. It's super interesting. This works really well until you do a hard count and you realize that nothing's 50-50. So again, just trying to help guys think about their relationships. And then you might hear about gender equity these days. So the idea of an gender equitable relationship. And that is one where the ideals of sitting down and talking through who's doing what, who's got the energy, who's got the capacity, and recognizing it as a continuous negotiation, and based on fairness and justice is the thing that's sort of coming to the fore. So these discourses around relationships sort of change. And so we do a lot of work with men, to try and help them think about where they sit within their relationships, because they're really, really important in terms of mental health. As we get older, it's interesting too that a lot of times what happens for us is that, if we're in a relationship, is that we might end up in a caregiving role. So when we polled over 1,500 guys about their relationship, and so women experience dementia um, at higher rates than men. So if you live long enough as a male partner, there's a very good chance that you'll be looking after a spouse who's experiencing a dementia. When we compare how that dementia caregiver experience kind of compares across men and women, women provide a lot of care to men, and they are far more likely to experience anxiety, low mood, stress, difficulty coping, isolation, and loneliness. And when we poll men, it tends to show that comparatively, not huge margins, but they tend to express at least less worry or anxiety in doing that. My point is that as we get older, our relationships change. And so can our role within those relationships. So we might start out as traditional and end up very traditional in being a provider and a protector, in the same way. So it's no judgment on how we show up in our relationships. I just encourage us to think about how we are showing up in our relationships, because sometimes our anxiety, sometimes our depression like spills over. And so it's just thinking about how we are showing up. It's interesting. We talk about men and we say, you should just go to the doctor and, get some help. It's a travesty that in Canada that up to 60% of the men who suicide have actually been in healthcare, receiving healthcare in the 12 months prior to their death. So I want to finish with some tips. I hope these help because they're intended to sort of help us sort of think through the things that we might be able to do to show up as best as we can. So I premise this by saying know and map yourself. Like spend a little time on you. There's a whole thing about how we're meant to be with our emotions. Warren Buffett, I think this is just such an interesting one. You'll continue to suffer if you have an emotional reaction to everything that is said to you. True power is sitting back, observing things with logic. True power is restraint. If words control you, that means everyone else controls you. Breathe and allow things to pass. Um, the ideas about guys being stoic and sitting on what they feel and not reacting is well worn terrain. I think it's ill-advised. I think, what we're really wanting to do is build some emotional regulation. And this is emotional restraint. And it does not help to sit on it. Morgan Freeman, this is an interesting quote too, self-control is strength, calmness is mastery. You have to get to a point where your mood doesn't shift based on insignificant actions of someone else. Don't allow others to control the direction of your life. Don't allow your emotions to overpower your intelligence. So again, I think this is, the work of sitting with what is felt and getting some emotional regulation. There's such a discourse about how we're meant to be, that I think, we can sort of have a look at these things and think, well, is that really me? Is that how I want to show up? Or do I want to be regulated in what I see? And we see guys sit on emotions and we see them spill over as anger and things that really aren't all that helpful. Anger and aggression are kind of cornerstones of masculinity in many ways. We celebrate them on the football field and whatever, like we're kind of into it, but it's built with enormous amounts of shame. And then I'd say, the other side of it is we kind of like we see therapeutic release, like in this photograph, like it's actually therapeutic release. I don't think there's anything feminizing or emasculating about this. it looks just authentic and an expression. And, again, I'm not suggesting we should all, tap our tears, as remedy, but, to think about how we can fairly express what we're feeling and sit with it, I think is super important. And I think there's ways that we can do it that are quite helpful, and there's ways that we can do it that we regret, that are very shameful. And so thinking about, how we can best deal with our emotions. When we go into professional healthcare, you folks are probably all quite entrenched, in many ways because you're going in for regular PSA tests, perhaps, so you've got this connection. Mental health is a tough go because a lot of times, we don't feel heard. We're not able to articulate what was going on for us. We feel like, they're kind of rushed. Um, and it can be really tough. So a couple of things that sort of help us think about mental health care professionals, because we don't always know, how it works. Psychiatrists, like it's covered by MSP in Canada. So that's, the medical services plan because we've got a public health gig here. So it's covered there. So, but you need a referral from a family doctor. Psychiatrists tend to be folks who work with you. They'll probably have a tilt towards medication for treating, kind of mental illness that's established in their diagnosis. And then there's psychologists, counselors, and social workers. So psychologists tend to work with you and will often ask you to reflect on your life. And so even like back to childhood and starting to work through that. And then using that as a framework to try and get into some of the current issues that you might have or some of the current challenges that you might have. Counselors tend to be more like talk therapy, and so they'll often start with you where you're at. So if you come in with a sort of a piece around, look, I've got this uncertainty around, this active surveillance, I don't know what to do with it, they'd start with you there and start to work with you and just help you process through. I think the main thing that I would say about mental health care professionals is that what's working for you with a mental health care professional now probably won't be working for you in 2 or 3 years or even 6 months. The idea is to build a team around your mental health. The other bit is a lot of us wait until we've got a crisis and then we go and seek mental health care. And guys really like talk therapy, but they'll often feel like they've got to show up with a problem or a crisis. It's not the truth. It's actually the antithesis. If you're able to access, talk therapy when things are going okay, I think it's a really good time to engage to build strategy and build resilience and full on strategy. So I see a counselling psychologist every twice a month. I'm not in crisis, but I've built up a battery of tests and a battery of strategies where when I do hit those challenging times, I've got a framework to sort of fall back on because sometimes we sort of forget or sometimes we just don't know how to deal with things. So again, just saying that, these mental health professionals are really, really important. And a lot of times our treating physician, be it an oncologist or a urologist or a family physician, might not have the space or time to get some of that talk therapy. So again, thinking about how we might get a specialist piece. Shout out to the groups. We did work in the prostate cancer support groups back in the day. It was one of our first grants when I got here. It was 2000, I want to say 6. There's a bit of humor in the groups. Welcome to the club that nobody wanted to join. But we did all of this work. But just to say, the humor is great because it gives a bit of light and shade. And I think that's important. It doesn't lose the messaging and it's a real calling card for guys. We talked about, sharing information and look at 80 of you across, different countries and sharing information because healthcare systems are different in every country, even every province in Canada does the business of prostate cancer differently. So again, even just sharing that information helps us be informed, helps us understand. And, knowledge is really important for us to, just avoid decisional regrets, and also help dampen some of the uncertainty about, what might come. We also found that in Canada, we had about a third of the folks that showed up to the groups were women. And I think a lot of times, in straight couples, female partners, kind of get left out, in some ways. So that it provided a home for them in some ways. And oftentimes the women would meet separately within the groups. And then we did some work as well, looking at, how do you get to a group? Because we could see that the groups were so important and so useful. And we found that one of the biggest, connectors to prostate cancer support groups was if a clinician, especially urologist or treating specialist, said there's a group in town, you might want to access. It was almost seen as an affirmation and endorsement. So again, the numbers would go up in that way. There's a lot of piece around peer mutual help because healthcare services are so stretched. This mental health piece about, guys connecting. And I think it's been fueled by the epidemic of loneliness and the US, Surgeon General's report that came out that sort of said, hey, look, this is a real issue, around mental health. So the idea that there might be mutual help in terms of mental health for men, I do think it can work. I think it can work really well. Here's an acronym that might actually help you think about it. People often ask me, they go, "Oh, how do you be there for other blokes and help them through, beyond the beer and the banter that's often associated with catching up with fellas, and your mates and your buddies." It's pretty simple, but we call it ALEC, and the A is for ask, like ask open-ended questions about how they're doing. If you notice any behavior changes in some of your friends, just maybe, just ask about how things are going, what's changed for them, what might be going on for them, what's stressing them at the moment, what's working for them at the moment. Give it a little bit of blend, but make it open-ended questions. Open-ended questions start with why, what, how. They don't start with is or are, because if we do closed-ended questions, we get yes, no answers, and the conversation is oftentimes over before it starts. The L is for listen, and as guys, what we tend to do is we listen with a view to solving someone else's problems. It's a bit of a go-to for us, and the trick is to listen and not do that. So just let them talk because it's the permission to talk and just let them go. Let them just have a conversation, share what's going on for them. Don't try and diagnose them. Don't try and offer solutions. Just a few more open-ended questions just to keep them going. We can encourage action, so, and in really subtle ways. So, I'll say things like, oh, I've got a mate and he was experiencing some stress and he did this. And I'm not telling the person what to do, but I'm offering an example of someone taking action. And then you might sort of say, well, what's worked for you in the past? Like, how's the sleep going? Or, how did you deal with it? You must have had these situations before, where you've been stressed. What's worked for you in the past? What hasn't? And then this one is C. This is the one we do really poorly. If a guy especially ever discloses to you and sort of shares with you that vulnerability about something that they, wouldn't ordinarily share, your job is to check back in within 24 hours, whether it's a text or a call or however you do it, but to check back in to norm it and to make another date in terms of catching up. So never leave them hanging because the problem with that is that they get very, very embarrassed. So a lot of times they'll feel like they've over disclosed. So this one is a quote from a young man who talks to exactly that. You have those conversations and you think, oh, have I said too much? What are they going to think? What's going to happen next time? and you just want to hide for a second. So this is really common, but we can fix that by just following up in really, kind of informal ways, but it's really just a check and balance. So me and my mates have a thing. We definitely text each other within 24 hours of having caught up because we've usually had deeper conversations and sort of chatted through some stuff. And just a shout out of appreciation and that we're going to, catch up in a month and try and nail down a date to sort of do that. Men are really good. They connect by doing. I guess, the criticisms of support, prostate cancer support criticism, maybe they don't do enough. There's not enough activity sort of connected to them. Men's Shed's been an interesting one, certainly in Canada, Australia, the UK, it's done really well. The idea that guys show up at this shed, it's a community space where they do activities that might be, something to do with woodwork or gardening or, learning how to put in a dimmer, those sorts of things, but they're actually doing, and then the conversations happen in and around those. And for guys that are, maybe retired and looking for a little bit of purpose or routine, this provides a space for them. So again, we know that guys do really well by doing. Also in the workplace, I'm sure many of you are still working in, this idea of how we can be a champion at work for other people. There's a buddy up program out of Alberta. The Canadian Mental Health Association does a really good job of getting guys to be champions in the workplace for other people in the workplace. So we know some particular industries, including the skills trades and construction, have very, very high rates of mental illness and also substance use. So again, trying to get a culture where it's okay to talk about some of those challenges are really, really important. So there's some of the programs. We've got a website that really is in gross need of some updates. Nonetheless, it comes out of the Cancer Foundation of Canada, Cancer Foundation. It's called If I Were Tom. What we did was we built this website because a lot of guys couldn't make it to a group, and it was before the days of Zoom when if you couldn't arrive at the group in person, there was no way, like we're doing today, that wasn't sort of happening. So we built the things into it that we thought were important from the groups. As I say, it's a bit dated because this one, the money runs out with the grant and then it's sort of stuck, but it's still attracting some attention and people find it useful in some way, shape or form. So again, that e-health space, this is a good one. It's called Heads Up Guys. It comes out of UBC. It's free. It does a really nice job of helping you think about your mental health. You can actually even do an assessment. It's got a whole directory of healthcare services for mental health that trade, especially in men. It's a really good site and it tracks about 50,000 unique visitors every month. And I don't know a clinic that's doing that. So it's 24/7. Really, really great resource and has lasted the test of time. So maybe even if you don't want it, maybe in terms of you've got some friends or you've got some mates that might benefit by it. It's got a really nice section for friends and family as well, which I think is so important to think about, the people in guys' lives who are often looking for strategies to help deal with some pieces. I'll just offer this one. I'll just check my time here. Yep. I'll probably talk a bit long. I'll wrap it up, but just I do want to spend a little bit of time on this one. This is like it seems really obvious, but I'll belabor it anyway. So just to say for ourselves, we can control mood and we can control anxiety, and depressive symptoms. Absolutely. What I suggest, here's my prescription. Map your week. Think about what drains you. So map your week over 3-4 days and make a list of the things that drain you and the things that boost you. That's the number one. Number two is pick one of those boost activities and write it in as a non-negotiable for your day or your week, and then run with that. So it's not negotiable. Nothing can supersede it. That is something that you will be doing. And three, stick to your plan on the low mood days. So a lot of times what we do is so an example of this for me would be I know what satiates me is if I can get out and do a bit of exercise. Like I have to be able to get a walk or a run in to just help me and clear my head. So I'll lock it in. I'll lock it in on the Wednesday. So I might get up on the Wednesday morning and I'm like, I just don't feel like doing it. So the trick is not to think about the completion of the run or the walk. The job is to start. So I might get ready. I might get out there. It might be 5 minutes, might be 10 minutes, and I might come back, but I've started. I've made a start on it. So even on the low mood days, and in fact, especially on the low mood days. Um, when I've got deadlines, this, breaking one job into many steps, this is called cognitive behavior therapy, fancy name for just breaking a problem down into the sum of its parts. So I've got a deadline, it's the 10th of April. If I think about the 10th of April, I just will be stalled. I have to break it down into what can I get done today? What can I get done tomorrow? What can I hit by the end of the weekend? And what can I, salvage pre-Easter? So again, it's breaking those things down. Really, really important because otherwise we just get overwhelmed with the enormity of things. And plan for pressure points. So when we know those things are coming, or when we know that PSA test is coming up, so working through the ideas of how we're going to anticipate that high pressure and defining two helpful actions to take in advance to keep you grounded. And so it kind of takes us back to map your week, lock in one positive activity. So again, building a plan because you know it's coming up and just building a plan in and around it. Two positive things, all you got to do. For me, I put the AirPods in, I pick out a podcast. I recommend this one. It's called The Art of Manliness. It's not what you think. It's actually just about stuff that appeals to blokes about our daily lives and our routine and how we talk and how we connect and that sort of stuff. Really good. You don't have to listen to U2, but I do. I put the 5 songs on, and then I love this thing on the phone where it's just pretty simple. And it monitors you. And so I do this probably 4 or 5 times a week. And when I'm not feeling super good with a run, I'll do a walk and it'll be a bit longer. But it's just self-monitoring, and there's not a day that my mood is not better when I come back off this. It's proven empirically. It's not just me, troping out. There's really well established, hard evidence that exercise in any way, shape, or form will help your mood. Um, there's a whole interesting thing about, precursors to mental illness and suicide. Just to say, what we need to do is look for a way of belonging. And I think even a group like this gives a sense of belonging, and we need to look for purpose. So we don't want to be a burden. We don't want thwarted belongingness. We actually want, to find purpose and to belong. And so again, just thinking back to those things that satiate you, the things that make you feel part of it, really important to tap those. And they can get increasingly hard when we start to sort of leave work and retire and the like. So I'll close out, just say gambling and social media are the new addictions. We tend to talk about those addictions being for young men. I actually think older men, middle-aged guys and older men are prime targets for these addictions. Really, really important that we think about, how much time we're spending with things that might be kind of satiating being bored. Really important to sort of stay away from these two things. Ahead of my Q&A, if we've got time, I thought I'd poll you guys because you're super, super smart, and I'd just say super experienced and in this group. And my two questions are, how would you sense Jimmy's pain? What are you going to say and do? And that relates to this scenario. And I think you probably might see this in your daily lives and maybe this group. And so Jimmy leaves for work early these days, and he seems to be staying late, even though he doesn't need the overtime. He's also withdrawing from his friends and his family, and he's distanced from his wife, and he's been changed by prostate cancer diagnosis. His thoughts are scattered, And he's distracted and edgy, especially around the time of his PSA checks. There's a bloke that's on active surveillance. So just, maybe in the chat or we can, engage this before the Q&A, just to say, how would you sense Jimmy's pain? Like, how do you see this? How do you pick this? And then what are you going to say and do? So I'll leave it there. Thanks for the time today. I appreciate being in such good company.
Well,
You're
thank you,
welcome.
John.
Great
And
hints, great ideas. Thank you.
and if everybody wants or anybody wants to respond to Jimmy's situation or personalize it, feel free to drop it into the chat and maybe we can pick up on that along the way. John, you've given us a lot to think about. But let me mention to you all that remotely I attended the European Association of Urologists meeting a few weeks ago in London, and they announced a new guideline. Uh, part of it recognizes psychological support formally as part of an active surveillance management program. Meanwhile, at the American Urological Association, they consistently have rejected doing basic screening for stress, um, anxiety, depression. They feel that there just isn't the evidence to do that on men like us, although they do recommend it for patients with testicular cancer. Their position is that the evidence doesn't support formal screening for prostate cancers. So, John, I don't know if you took that all in, and I'm happy to repeat it, but what do you think about the professional organization, at least in the United States, saying, no, it ain't worth screening these guys?
Yeah, look, it's interesting because a lot of times, when I talk about depression or, an anxiety, it's like on a continuum. So there's depressive symptoms where it might just be a little bit episodic and it might be something that's totally manageable, with self-managed. Same with anxiety. A little bit of anxiety, sometimes can give us a little bit of an edge, and it's just when it spills over and then all of a sudden we're not sleeping and it's just not helpful for us. It's actually stalling us. So I understand, the continuum of what they're saying, but I think I just don't think I think we wait for the problem and then we say, oh well, we should screen for the problem. And if you think about prevention, then I think maybe we don't need a screen, but maybe we need strategy that comes along with, okay, I'm committed to this active surveillance. I know it goes against the grain of a lot of things, about, or I've got off forgoing options and I've got noise coming at me from relatives and people who think I should be doing something different, all of those things. And so then working through a prevention plan for so as you're not coming off anxious or you're not coming off defensive, that you're able to stick with it. So again, the medicalization of it, for the diagnosis, I'm like, oh, that's kind of the crisis point. It'd be great to build it into prevention, like as a part of what it is to be on active surveillance. Just some tips and tricks, probably more elaborate than what I've shared today, but just to say that those things, offered up front, I think could help us be better, in dealing with what's a pretty unique circumstance when you think about it.
You mentioned self-management a moment ago. Would that include things like attending support groups, exercise, Tai Chi, yoga?
Yeah, so these days the places that guys find their calm is really diverse. So yeah, we've got guys doing all of those things. And I would say, to the support group piece, we studied it, back in the day, and it was all in person, and now it's online in a lot of groups and stuff. And I still go out to the groups in BC and do talks and the like. But just to say, there's nothing better than connecting, with other folks. And even if it's connecting around a particular thing, that you can't always get a conversation with your other mates, because it kind of brings the party down, or they're not interested, or they just don't have the context. I think these groups are just massively important for a sense of community. And if COVID taught us anything, I think it taught us the power of social connection. Like, I mean, I think it's just so critically important that we do connect. And if we connect for purpose, like on these support groups, why not? I think it's valuable. You're really careful about that you're not providing, direction or telling people what to do, but you're sharing experience that helps to norm the fact that we're all a bit stressed on some of this stuff, that there are strategies and things that are working for me might work for you, but it's just trying to, be decent for each other. Yeah.
You, you mentioned, observing support groups and so on. I wonder, have you picked up or do you have an opinion on how good a job the urologists do in including support groups and peer programs in their care plans?
Yeah, so look, I could talk that paper that I shared with you that came out of Canada, in the Canadian context and certainly in the British Columbian context, some of the urologists had really good ties with the support group. So they'd show up and they'd do talks. And they were supportive of the idea that the guys, that some guys might benefit from the groups. I think one of the things that happens, with the groups is if there's a mention of a group, then it's legitimized. If a healthcare professional, sort of says there is a group, they don't necessarily even have to endorse it fully or, direct you. I think the mention of it usually is enough for most guys to consider it. I think just on support groups, I always encourage the leaders of support groups to recognize that not everyone stays for a long time. Maybe the active surveillance group is one of the exceptions to that because it's a bit of an ongoing conversation. But a lot of guys will come into regular prostate cancer support groups and they'll come and go, or they'll get what they need and they go. Oftentimes, I'll be trying to make a particular decision around a treatment, and some of them stay, but a lot of them come and go. And I reassure the leaders of those groups that if you can do your job, of helping that guy, and he just needed one or two meetings, then that's pretty good. Like, not everyone's going to stay. Not everyone's going to sort of give back, or, they move on, they bracket the experience and move on. So again, I just think, a shout out to the groups and the work they do. And yes, the referrals do matter. So if you've got connections with healthcare providers and you've got people who are presenting at your group, it's a great way for them to recognize the group. Because for me, showing up here today and there's 80 on the call, like, I would have no hesitation in, referring someone who was thinking about active surveillance and wanting to sort of get the wisdom of other guys. I mean, have no hesitation in referring to you, like referring him to your group. So again, it's that word of mouth. Yeah.
John, I should point out that we started this group almost 10 years ago because
Mm.
a lot of the guys on active surveillance would go to these general prostate cancer support groups, and they were turned off and
Yeah.
frightened by the extreme experiences some of the more advanced men had. So we started this mainly to reach out to active surveillance
Yeah.
people. One thing that impressed me that you said is you have about 30%, or you've observed about 30% of attendees and support groups are women. Um, we don't attract that many women. Some of the ones that we do attract are really into it and know everything and are really the guides for their significant others. But I'm going to turn this over to Rochelle so we can get a women's voice in here. And after that, David and then Jeff, maybe two questions each, and then we'll rotate back. Rochelle, you are here, right?
I am here.
Good.
Okay, so we had a couple of questions that we wanted to ask. First of all, it's great to see you again, Dr. Oliffe. So for the men who are living this in real time, what would be the first couple of steps that you would suggest for dealing with their anxiety? What would be the first couple concrete things you'd suggest to do?
Yeah, I mean, I'd go back to that. The self-management piece, I would definitely just I know it seems so basic, but we don't do it. And I would just the self-management piece, I'd just say, look, what drains you, what is draining you and what is not? Like what is rich for you? And I'd put it on a scale of one, 1 to 5, 5 being the thing that satiates you. And I would so build that in to my day, to my week, and I would not move that piece. I would keep that piece. The other bit I'd do is I started seeing a counselor, I reckon it's 3 years ago. And I just wish I hadn't waited so long. And I was, like I say, I'm not in crisis, but it's the kind of conversation I cannot get anywhere else. Like I actually really, it's just talk therapy, and I talk about what's going on for me, and she has ideas for how I might manage that better. She helps me get to what I'm actually feeling. And I just think it's rare. Like even when you're partnered, sometimes that outside objective, coach can be super helpful. So I I wish I'd started that earlier because it's actually just helpful. It's just like good everyday stuff. So that'd be a couple of things I'd suggest from my viewpoint. Couple of great starting points. Build the team before you need the team. You know, think about what you're doing rather than like just the end product of what you're feeling. Like, what is it that kickstarts me? And so, my revelation with the running is that it's not the run, it's the walk back from the run. That's my cool down actually helps me, but it's being out there. It's actually having a crack. Yeah.
Awesome. Thank you. Do you want me to keep going, Howard, or do you want to switch it
Well,
over?
why don't you throw out another question, then we can move over to David, and he'll do two, and Jeff will do two there, and then
Perfect.
my turn.
Great. Christy actually put a really good question in the chat, and she was asking, how does active surveillance shape a man's sense of control or identity?
Yeah. So, um, I think control is the thing that we crave. So it's that you have agency. So so if you go in and you start doing more or you start researching it, then you've got an element of agency. You've got some control. Like because you understand things, you're engaging it. Other people's sense of control might be I'm going to bracket this, I'm going to blunt this, and I'm going to stay off the side of it, and I'm going to focus on everything but this. And I don't think there's a wrong or a right, but both of those things you would argue, kind of get you into a place of control. And so, I mean, controlling what you feel or controlling, what about a certain thing, and like active surveillance. So, that I think it's when our control gets threatened or taken away from us that, a lot of times there's a huge anxiety in that, and there's a huge loss of, you know, uh, kind of confidence and the things that erode us. And especially if we've come from backgrounds where we have had some agency or we've had strong agency, you know. I think of work, and work relationships and stuff like that. A lot of times we have identity there, and things can get threatened very quickly. We've had guys on active surveillance who stayed in jobs and went on active surveillance to stay in the job because that was their identity. And again, I'm not suggesting there's any wrong or right here, but I'm saying, that control, that sense of agency of not being passive in it, I think is very important for guys. And sometimes we don't realize it. And when I talk to guys with decision or regret, um, oftentimes they wish that they'd spent more time up front getting some control of their situation, like feeling that they had control to make an informed decision. Yeah.
Yeah, Dave.
Thank you.
Yes. Hello, doctor. Thank you so much for your fantastic presentation. And your background of research and published research is really impressive. Wow. I had no idea, really, coming to this meeting, how extensive you are in the field in terms of your research and the time that you spend in it and published in peer-reviewed journals. So thank you for being here. I have a question on AI, artificial intelligence. Have you found that any of them are being of any assistance to people in dealing with anxiety in this area of prostate cancer? Whether it be ChatGPT or Claude or Perplexity or Google's Gemini
Yeah.
or any of those. What have you found?
Yeah, it's so interesting. Like it's the internet 2.0, isn't it, really, if you think about it, and it's very emergent. So, I think going forward, I think it will get better. At the moment, there's a lot of misinformation, and there's a lot of people talk about this like this affirmation of it will tell you that you're right about everything, and maybe that's not that helpful, in some ways. It befriends you in some ways, or some of them do. So again, I think it's one of those ones that if we think creatively about this and we think about something that we will need to mature and need to grow, then I do think there's great potential in it. And I think it reminds me of the days when, the calculators came out and everyone said, oh, no, you've got to know your rote learn your times tables, like don't use the calculator. Like this thing is here and it will get used. And so I think the caution is to say it's going to get better. It's one of many tools. It can be helpful. But of course, there's that high chance of misinformation as it currently is. When we start to work those algorithms a little bit in the ChatGPT space, I think there's going to be a whole other sense of how this can work well in terms of coaching and whatever. And my experience of it personally is that it befriends you, which is kind of interesting, and starts talking to you about your football team and all sorts of stuff. And it's kind of a little weird, but also when I'm trying to make decisions and that it just seemed like too difficult, I've consulted it, and I mean there's some helpful things that it's helped me think about some things I might not have thought about. So I'm very interested in it, and I just don't think we're quite there yet in terms of going, oh yeah, this is going to be the last bastion of mental health care. It's not, but I do think it's got a place. I think it's very emergent though. Yeah.
Do you remember the really old program? I think it was called Lisa, where you could interact. It was set up, it was a loop of questions. Uh, and, I haven't sought advice myself like this, psychological support. But do you remember Lisa and how different Lisa is from what's going on now?
I don't recall Lisa, but yeah, it's such an interesting space. It's just, you know, I'm not against it. I just probably I think we all need to understand it a little bit better in terms of its legitimacy and that it's pointing us in the right direction for things. Yeah.
Yeah, well, Dave, that was a
Thank
great
you.
question. Why don't you go ahead with another?
Okay, great. I have a couple, but I want to ask you about you talked about depression and mood and lithium carbonate versus lithium orotate. Have you had any of the people that in your support groups or people that you've talked to address that particular supplement, the one that's over the counter?
So no, but what I could say is in our work more generally with guys who experience mental health challenges, whether it be depression, anxiety, suicidality, they often talk to us about medications as sometimes being quite helpful, but also craving some self-management, and on occasion sometimes they feel that the medications take them further away from their self-management and introduce some other challenges for them. So I'm not pro medication, anti-medication, and certainly can't talk to the lithium piece in detail, but just to say, when we talk to guys, their predominant interest is in talk therapy. Yeah, across the board. And so it's just interesting to me because we tend to say that guys are stoic, and it's interesting to me that in a confidential, private kind of situation where they've got some trust and rapport, that they do gravitate towards talk therapy. And I'm not saying excluding medication. I think there's a real case for medication in especially in complex mental illness issues. But yeah, I can't comment specifically on the particular drugs that you mentioned. But again, just to say, from a pattern point of view, guys are increasingly taking on talk therapy.
Wonderful. That's great. Back to you, Howard.
Okay, back to Jeff.
Hey, John, thank you, and welcome to everybody. I have a question, a couple of questions, John. One of them is about the relationship a patient has with a practitioner, be it a urologist and a radiologist. And a quick story of my own. The first urologist I had came off like a dictator. I quickly left him. And then secondly, sometimes radiologists can be a little iffy. How do you develop trust with your practitioners in active surveillance?
Yeah, vitally important, right? So, and we find this, the major feedback we got from guys who were trying to secure mental health care was that trust was vitally important. I think the way to develop trust, I think you practitioner wise, is if you want to feel like they know you, like they know enough about you to tailor the treatment. And I think it's really important to be known, in that way. Like, so as you don't feel like you're getting the generic, that you feel like they kind of know you in a sense, and know how you are, your preferences, and that there's a kind of a collegiality around it and a shared decision making. Because it's vital, isn't it? For the interpretation of the PSAs, for how long you're going to stay with it, for an agreement about where the stepping off point is, or if there is a stepping off point, and then the whole treatment thing, if that's on the card. So again, it's having that conversation that they're committed to the AS just like you are, and that you're working together. So that's the formulation of trust. When we talk to guys about, moving on from a practitioner, it's when they think they're getting, the kind of the run of the mill, or they're not really known, or the guy's just busy. You feel like he's rushed, or he or she is rushed, and you're just getting the basic kind of what everyone gets. And I think I encourage you to follow those instincts. You've got a right to you've got to feel good about these things. These are highly emotive issues. And you've got to be confident in who's with you, for sure.
Okay. Now, the second question has to do with your discussion of running and exercise. And there's been a couple of mentions or questions on the chat about lifestyle. Would you comment a little bit more about exercise? And do we have physiological, medical, scientific evidence that exercise actually helps our mood?
Yeah, 100%. Like, it's an empirical truth. It's an absolute empirical truth. Time and again, it will lift mood, it will lift your affect. And so, I think the prescription around, oh, well, let's, make sure it's 150 minutes, a week, and all this sort of stuff, I think puts a lot of pressure on us. I'm like, do what you can, and then actually think about, how you're coming off those walks, or, runs, whatever it is, and just getting outside. Again, the empirical evidence says yes. And I think that self-monitoring, would affirm that. So it's really well known. Of course, the other things, and I know, we talk about exercise all the time. It's a go-to for guys too. Like it's the one health promotion thing we do probably better than other genders. Um, there's some other things with like, diet. Again, I know this gets spooked all the time, by people, but just to say that diet's really important in terms of, just getting some decent protein, especially if you are exercising, and balanced diet, and sleep is the one that's super important as well. Time and again, just we see that folks might be doing too much screen time before they're going to bed. They might be eating too close to going to bed. Just that what they call sleep hygiene. It's a real important one for waking up in a way that you feel like you got some rest and you're ready to go. So again, they're basic lifestyle things. They're not the only things, but they really are important. And when you talk about control and the importance of control, if you can establish a routine and you've got purpose in that routine and that builds in those things, it makes a massive difference to your mindset.
Thank you.
Hey, we're right at the time when we're supposed to quit our Q&A. Maybe we'll take another round of questions. We'll sign off from the recording, and then we can do a support group. And John is welcome to stay and observe and critique, but keep your critiques nice. Okay, I'm going to go with one more question here. Okay, many partners are watching their partner on active surveillance, but they may not hear the word anxiety. I'm anxious, or I'm really worried about this. From your research, what are some of the quiet signs that the partner may be able to pick up other than an outright admission of anxiety?
Yeah. So we use the word stress. That's the proxy. So guys, it's a go-to word. Yeah, I'm a bit stressed. And so you'll hear that. And clinically, we wait for that. And we know that it's depressive symptoms or, a bit of anxiety. Like that's what it is. So that's the code. That's the code that we hear all the time. If we'll often talk about behavior change as well. So if someone becomes withdrawn, just starts to disconnect a little bit, they're not their usual self. They might be quick to be irritable. They might not have the patience that's going on for them typically, so their demeanor might be shifting. And so underneath that, it's my mention of how guys show up with depression. It's like, we often misinterpret it, so because guys can just be angry or they can just be a bit irritable, the angry old man type thing. And as we get older and all of that, all those tropes. But, the truth of it is like a lot of times there'll be an underlying kind of depressive symptom there, or there'll be some anxiety that's troubling them. And what guys tend not to do, or what we battle with, is getting to the emotions and trying to work those emotions out for why we're feeling what we're feeling, rather than spraying it. So again, if you're seeing, kind of some, unusual or some changes in behavior with your guide, that's kind of like, that withdrawing, bit quicker to, be impatient, they're usually pretty good signs that there's something underneath. And sometimes you can help them actually think about that. And sometimes like the permission to talk. So those open-ended questions with ALEC, you can do them as a partner and literally just give them permission to sort of say what's going on. And, that processing of what you're feeling is like, that's rare for a lot of guys. So again, It might be you don't have to solve it, but it might just be enough for them to sort of think through what's really happening for them.
Rochelle, how about a really good question?
Oh, you put me on the spot. Okay. I had a few here. I think we've covered just about all of my good questions. Oh no. No, yeah. They were covered. Um,
Well, okay, Dave, how about you?
I think that Dr. John did an incredible job, and I wanted to ask him what the E stood for in ALEC. I was going over my notes. Ask, listen, E, and then check in. What's the E for? And ALEC, ALEC.
Yeah. Encourage action. Yeah.
Okay.
Because
Okay.
guys are really good. Guys are really good with if it's action based, you might notice that we talk more when we're shoulder to shoulder. We're not great, you know, like front on, and so it's part of why Zoom works because we are shoulder to shoulder. But it's super interesting. So a lot of times, yeah. So we encourage action. So
Thank you.
yeah. So oftentimes there's an activity associated with the talk. Yeah. Yeah.
And
Perfect.
Jeff,
Thank you.
one parting shot.
Yeah, okay. This one's gonna spin some wheels. All right. I grew up.
Should I sit down?
You might.
Okay.
I grew up in the days of guys used to get around and share a joint. Okay, we were young, we were having fun, we were listening to music. Quite frankly, I know some guys that still do that, and some of them take gummies. Now, some of them swear gummies. Again, it's self-medication, which we do not recommend. But John, is there any room in the world of anxiety for guys doing something like out of the 60s? I mean, some of the rock and roll bands are still going.
Yeah, no, I think I've seen some of them too, and they are still going. So, yeah, just to say, so, I mean, there is some research that's occurring that's looking at the specific parts of marijuana, and there is some emergent evidence that there can be some benefit to some parts of marijuana for anxiety, that they might actually have a therapeutic effect. The fact that it's legalized, at least here in BC, is interesting. And oftentimes, following those decisions, then there'll start to be evidence. So, far be it from me to suggest that there's a proven, therapeutic value, and so I obviously can't do that. But I would say that I think in an emergent way that there'll probably be some claims that and maybe some empirical evidence that some of that stuff, in its right formula, can be of benefit. We've seen some of the pain management stuff with some of the marijuana, and again, that it's not smoked, that it's in different forms. I think it's an emergent area. Not one that I can endorse, obviously, but just to say it's out there, and I think, there's when things are legal, like they are in BC here, I'm sure that people are experimenting with some of that. And the self-medication side of things is that, I guess, one of the keys is that if you're, seeing a clinician, is to let them know what other things you might be doing. Because I think that's important disclosures in terms of, that everyone's in the know with some of that, if that's a sort of direction that you're heading.
Thank you.
Yeah, thank you, John, and thank you everybody for coming.